Hi, I'm Frank Diamond, the managing editor of Infection Control Today, where we're trying to give infection preventionists and other healthcare professionals the information they need to do their jobs better, in any circumstance, but especially now in the midst of a worldwide pandemic like COVID-19. And for any healthcare professional, doing a better job often involves continuing medical education, which leads me to my guest today, Mary Ellen Beliveau. Mrs. Beliveau is the CEO and founder of Knowledge to Practice, a company that develops continuing education platforms and tools. Mrs. Beliveau has an extensive background in healthcare that includes over 20 years of experience in creating innovative postgraduate medical education curriculums. She's a CLO consultant for the Dana-Farber Cancer Institute and a member of the Board of Trustees at Johns Hopkins. Ms. Beliveau, thanks for being with us here today.
Great to be here. Thanks for inviting me.
Okay, so I have to ask, has COVID-19 affected how CME is getting done? I imagine like everything else, a lot of it now has to be done online, right?
Yeah, I think it's actually a good thing, to be honest with you, is I think a lot of providers of medical education are learning to more effectively and efficiently deliver online tools that are more easily accessible than destination conferences, which has sort of ruled this world of postgraduate medical education.
Is there something lost in not having the face-to-face?
I think there's, in terms of developing relationships, referral relationships, I think the live conferences are fantastic about continuing to connect physicians to one another, especially specialists to generalists, and vice versa, actually. But I think true learning is really not one size fits all. And with the amount of administrative duties and the rate of development these days, literally outstripping physicians' ability to keep up, it's really most important for us to provide physicians with self-assessment tools so that they understand where they have and lack mastery. They focus their time on the areas where they don't have mastery and get their competencies up to speed so that they have more continuity of care across the individuals in their healthcare system, and the individual is spending the time in the areas where they should spend their time and focus on their weaker areas.
You alluded to something that I've often wondered about, and I guess it could be in any profession, and that's information overload. I mean, if you're a physician, you could spend all your days and nights just reading the literature.
That's right.
How is that obstacle overcome in?
Yeah, so I think, COVID really has dished that out exponentially for this marketplace, right? The global production of information, some sound, some not so sound, was literally overwhelming. You could talk to academicians on the front line of New York saying, I'm not even opening my emails anymore. And even my medical specialty associations are forwarding me articles, which I have to somehow read and somehow distill and then figure out how I'm going to change the way I practice. And it's been proven for many, really more than a decade now, that things that are read is information that goes in, but it very, very infrequently results in changed behavior at the bedside. So that's one of the things that we do. We are actually both ed tech and adult learning experts. And so when we developed our COVID curriculum, it was really designed so that we would be the ones doing the surveillance. So really scanning everything coming out from CMS, from WHO, from everybody across the world, all the subspecialty societies and specialty societies, working with top line ED physicians, ICU leaders, cardiologists, people that are in infectious disease specialists that are on the front lines, recognizing that part of their struggle was they were taking physicians that have never worked in that spectrum of care and needed just-in-time learning. So if I'm an OBGYN and all of a sudden I'm in the ICU, I don't know how to run a ventilator. I've never run a ventilator before. I could be the best OBGYN in the country, but suddenly being put in a different area of practice and be expected to be at the top of my license is almost impossible. So we both needed to distill the evolving data for the specialists, but we also needed basic education, just-in-time education for those people that were first-time providers on the front lines in the acute spectrum of
Basic
care.
question. Do you feel that some professional healthcare specialties or subspecialties aren't getting the continuing education that they really need?
Related to COVID or in general?
Both.
Yeah. So I think right now, I think the specialists often will look to get their education from their medical specialty society. And I think from a science perspective, it's obviously solid because it is generated from the academicians from across the country coming together and developing consensus. So the quality is good. I think the challenge is our medical specialty associations mirror the challenges in healthcare systems right now, which is the siloing. So one an advanced practice practitioner or an MD, and where are they? Are they delivering care in the acute sector? Are they in the inpatient setting, or are they in the outpatient setting? As I think about diabetes and its impact on how I treat a patient in the ED, it's different than my guidance on how to help them exercise and have the right diet from the outpatient perspective. So understanding the spectrum of care and delivering personalized learning based on what that individual is struggling with, what their gaps are, and delivering it to them in a highly accessible way is really a contemporary concept in this area. And as is the concept of the enterprise actually recognizing that they have a responsibility relative to human resource development, or sort of the last bastion out there that has taken ownership there for years. You know, if you think about almost every other vertical marketplace out there, right, they all have human resource development resources and how to expand and continually to professionally develop and advance and invest in their human resources. Healthcare, has, physicians have been brought up to be autonomous. They've been trained to be autonomous so that when they finish their training, they're actually ready to follow a patient all the way through and take care of them all the way through. And they have been held responsible for selecting their own education. And that does not unite continuity of care across a team of, say, 150 cardiologists inside one institution spread across 7 locations. So the concept of having accountability from the enterprise to keep updated curriculum and have a standard of engagement and scores across that content doesn't exist in this space the way it does exist in the financial space and maintaining their licenses and their scores as they go, right? It's very different in this space.
We talked a little bit about information overload, but that has to have grown exponentially since the internet, and it has to be, it's a blizzard of information now about COVID-19. So how do you sift through what's good and what's not so good?
That's the challenge, and it results in chaos in the front lines because everyone's getting different information that they trust or don't trust. I can give you multiple examples, but I won't go that deep. But I think that's come to something like COVID, where evidence is not yet defined and the data is still coming out based on the complexity of cases. You have to really trust someone. And I think there's very few people, like I said, most of the medical specialty societies right now are sort of aggregating what's out in the public and telling them to read those things. And what we know is the reading of those things doesn't often change behavior. It creates insights, but it doesn't change behavior. I'm trying to get as deep an insight as possible on the command centrals and how hospitals have adopted their command centrals to be effective in a pandemic, when command centrals have generally been designed for storm-based issues, and how have they quickly turned, who's been successful, who hasn't been successful, and that's where I've been.
Can you
say that again?
Can you mention names? Who has been successful? Who hasn't?
Yeah, so it's interesting. We are now on our 10th case study of, and for the most part, people that have been successful, they've been successful in parts at Johns Hopkins, they had a really strong ability to get control of what information needed to get out at what frequency. They immediately defined a group of people that would meet regularly and would communicate effectively to their team. I think the concept of training certain things like the donning and doffing of all of the safety equipment, the PPE, might have taken more time than they anticipated. They thought it was going to be more intuitive. You look at someone like Columbia on the front lines. They didn't really engage their command central until later in the process. So when you look at them, they had the heads of each of their service lines were producing information relative to that scientific area. So whether it was neurology, oncology, whatever, and giving it to their service line. But there really wasn't that sort of across the continuum of care and across the various delivery sectors of care, which was really what was most critical with COVID, because you all of a sudden had practitioners practicing everywhere. And that awareness that just-in-time learning for a dermatologist suddenly working in the ED is necessary. As smart as they are and as competent as they are in dermatology, it does not make them competent in emergency medicine, right? And it puts a lot of stress on the leaders in the ED to make sure they're giving them the right guidance, which means searching for all of the information on COVID and how I have to think about structuring my landscape and separating COVID patients from non-COVID patients. I don't have time to read the literature in between, right? So it's really thinking about those layers and what is the institution's job? What is my leadership's job? And then what are my director's jobs? And then what are the sort of attending's jobs, right? And I think that was something that was really difficult for almost all of the situations, all of the providers to get their hands on. I don't think anyone was thinking about things like, how are they going to get to work? What transport, they weren't thinking about, well, they're going to need to stay in hotels. How do we support them to be able to stay in hotels so they don't bring it back to their families? How do we, I know I'm on the board of a small hospital here, a community hospital, and we turned what was, a cafeteria for patients' families that were no longer in the hospital. We turned it into a place where any of our staff could go and get toilet paper, could go and get milk. So on their way home, all those things that everyone was complaining about they couldn't get locally, they could get here. So it's interesting, right? Different I've found different health systems had different innovations, doing different things that were quite innovative, quite successful, but they all had gaps in one area or another. And so my goal is to try to get as many case studies and then start to help people reflect and ultimately be able to share case studies that will enable people to really have a comprehensive thoughts around any pandemic and how they will think about addressing that as an executive team. I think COVID has really pointed out to the administrators that they do have a responsibility and a role as it pertains to having a set of clinical protocols that my entire team is going to be commonly versed on and a common set of curriculum. And that is what will be behind continuity of care as the government, as the US government is asking us to deliver value-based care versus volume-based care. Having that understanding is critically important in driving that continuity of care. And you cannot drive continuity of care if each individual is searching for their professional development autonomously through various resources. It's going to continue to not support interdisciplinary team-based care. It's going to support the excellence of individuals versus the perspective that we all bring expertise to table and how do we work together.
Have you seen Mary Ellen Beliveau? Thank you so much for visiting Infection Control today.
It was great to meet you. Thanks for your time.